Hey guys, welcome to another episode of the Optimal Health Podcast. I've got an awesome guest back once again today. Dave Lee, thanks for joining us on another podcast.
Thank you for having me once again.
I appreciate you being here. Now, it's been a few months since we last chatted here. Yes, we've had some messages on social and I've been in the TRT Academy group and things, but what is new in Dave Lee's world and also the world of TRT since we last spoke, which I think was about October, November?
That's a good question. Timely question, because as of a couple of days ago, the primary pharmacy that most people, including myself and my clinic that I own in Latvia, use in Greece has been suspended for operations. So fortunately, my clinic has been building our own pharmacy over the recent months, and we've just received it, or by the time this goes out, we will have just received approval from the EU to operate. So we'll be making our own HRT-based testosterone cream, which is really exciting, as well as the oral sustained-release hormones, things like naturally desiccated thyroid, which is a bit harder to get in Europe. And so that's really, it's very sad that this pharmacy got shut down because it messed with a lot of people's treatments, but exciting on our end, and good timing that we'll be able to pick up where they left off in some aspects. And in Australia, I'm building a couple of new projects at the moment, one really targeted for people who are on a lower income bracket, who are wanting to still get the best possible treatment, which I think is a really important initiative. And the other is a bit of a boutique concierge thing where I'm hoping to work with a small handful of guys, start to finish, on their protocols to get them really dialed in. So at the moment, working on multiple new projects, which is not what I like workflow-wise. Like, I'd rather just work on one thing. So I'm looking forward to all of this stuff being done in a few months, so it's all up and running and kicking off, and then I can just get back in the trenches doing what I was doing for the last 8 years. So yeah.
Building a good reputation doing it as well. Interested about the pharmacies though. Why did they end up getting shut down? Do you know?
Well, it's hard to say. I haven't heard directly from the owner of MP Labs, so I've only had very honest and good relationships with him. And when I see an article come out like what I see has come out, and granted, I have no idea what's happened, but in Australia, when something in this industry happens, the media will make an example out of them to kind of deter other people from entering the space. So when I read the article, again, as someone who's, as I said, my clinic is working on opening a pharmacy and there's a lot of regulation-based stuff. I read the article as it looked like they didn't tick the box for all the approval needed to compound the peptide angle that they'd recently moved into. That's what I could ascertain from it. But the news media article made it out like they were running an illegal steroid operation and have been raided and shut down. So it's anywhere between those two spectrums. I don't know where it falls on that, but I'm inclined to say that it's the most conservative of options at this stage.
It's interesting you mentioned about obviously the peptide side of things, but we're seeing a lot of where the FDA approval is or isn't happening, all this sort of stuff. I'm hearing different places potentially getting shut down. But you mentioned, tell us what the difference is with a compound pharmacy and I suppose what a standard pharmacy?
Right. So most compounding pharmacies don't compound injectables, and some do. So okay. The reason that why only some do is there's a lot of equipment and a lot of sterility and a lot of investment needed to do that kind of stuff. So when we look at a general compounding pharmacy, they typically make, they do a number of things which is really important. So one thing that they do is for elderly people. So they will combine medications into one capsule, or they'll create custom dosing of certain things and provide it in a way that is manageable and work withable, which is really important. They'll also basically make things that are not available as a commercial preparation. So you can, it's an awful example because I hate hair loss drugs. We've both dealt with hair loss clearly. But the hair loss drug dutasteride and finasteride, that isn't commercially made as a topical preparation. But when people use it topically, it has to be made topically by a compounding pharmacy. So they make things that are not part of the commercial medications that are available in a given country. And that opens up some really exciting opportunities to be able to make things like a 20% HRT-based testosterone cream, which gives people an alternative route of treatment. Or in certain countries where the testosterone, let's say, only comes in an ampule or a preloaded syringe, the compounding pharmacy will be able to make it in a 10 ml vial so it can be drawn and injected easily with an insulin syringe, ideally even in like a thin, low immunogenic carrier oil like MCT oil.
Okay, so it's I see that only as a positive thing, really. You get a decent compound pharmacy, it opens up more flexibility with administration methods and everything else as well. So, yeah, just wanted to clear that up for some of the guys listening that they may hear the word compound and wonder what is that. But I'm interested in your take on this one. Like, my Instagram has gone nuts recently. It's a great thing. I've been putting out a lot of posts talking about like things that guys do that seem selfish, but are signs of burning out, exhaustion, things that could be symptoms of low testosterone. As we know, like there's so many symptoms of low testosterone, but is it the testosterone? Is it what else is it going on? And it's shown me kind of how much of a lack of awareness there is where people don't see the connection between our physical health and our mental health. So I personally know myself that I was, like, for example, shaving my head. I was really worried about that, but actually when you've done it, it's actually so much easier. But even things where I've just got, I don't know, I would say with myself, I became a victim of certain things, and then I just had to snap out of it and get over it. How are you dealing? I'm assuming you're probably getting some messages from people as well. In fact, we've spoken about one guy together in the DMs, but how do you deal with it when guys, they aren't aware that their mental health is being impacted so much by their daily habits?
How do I deal with it? I like to think I deal with it pretty well, but it pisses me off sometimes. But it doesn't piss me off at the individual. It pisses me off at the paradigm. Like, it's a symptom of the paradigm. It's not their fault, because that's the belief system that we've all been indoctrinated in for some time. When one of the reasons I dropped out of my master's in neuropsychiatry was because I was studying at the Czech Institute at the same time. And there was just such a blatant disconnect between, you're taught in neuropsychiatry that people just have broken brains for no reason. And then you're taught in the Czech Institute by Paul Czech all the important things that go into how someone, basically lives and breathes and operates as a human. And it's very obvious which one made sense. I mean, there were some things that were like, they both hit and miss, but it was very clear which paradigm made the most sense. So, that was a contributing factor to why I dropped out. But up until that, red pilling moment of understanding that, I mean, that was my default assumption as well, is that they were kind of separate. And once you apply a common sense lens, you can see how they're interconnected. And it's very interesting when people say, oh, I went to like a gastroenterologist, like a gut doctor, and they said that there was no connection between diet and IBS, which is, irritable bowel syndrome, which is just symptoms of the gut being irritated. Yeah. And it's like, well, there has to be at least some connection, because that's that's the only thing that's physically passing through that area. So there has to be at least some. Has to be at least 2%. So how do I deal with it? I think I always come back to the saying that you can lead the horse to water, but you can't make him drink. And I think that's the way that I've learned to deal with it from doing this for almost a decade now, starting with health coaching primarily, is that it's really best just to, and this is why I spend so much time focusing on making content that's like lectures and long form, which is that you can educate the people who want to learn, and you can show the people who want to learn what they want to know, but you can't, in an unsolicited fashion, shove that information down people's throats and expect them to be receptive to it, given that it's also like the uncomfortable path, because it's the path that doesn't involve just taking a pill or taking a supplement or whatever. So I approach it with a degree of compassion, in terms of, I'm like, I don't get frustrated at people individually when they're not seeing the connection. But when people reach a point that the outcome of the habits is causing them a problem, and they're reaching a roadblock, like a barrier from it, and they're not willing to look at it, even when other interventions have failed, that's when I think that all you can really do is continue to educate that person and allow them to opt into that education if they want to receive it. And eventually it will become clear as day if they choose to follow that. But if they don't want to, then, it's just something that you just kind of have to bless it and wish them all the best with.
I suppose as well, it's one of my frustrations with social media. Like my business is built on social media. You go into a lot of physical talks and stuff, but essentially your content gets out there on social media, right? So it's a blessing and a curse. But it's these people that they say they want help. They message. Like I've got a reel that goes out. It's like DM or comment ready, and we can chat properly. And I go in there, and people are like, "Yeah, I want to change. I want to change." And say then they're being worried about being sold to, but also I say, look, let's just get on a call and let's just have a chat. I am not going to charge you for the call. Best case, if you want to sign up to something, then great, we can sign up to some health coaching. If not, you leave the call with a couple of things to implement. And I think there's such a fear, one, of being sold to, but also actually you get a lot more attention a lot of the times when we're sick. I know I definitely did. When I was feeling low and depressed and I would put something, I'm feeling crap on Facebook or something, you go, oh, what's up? DM me. But if you say, I feel amazing, you don't really get as much attention. And yeah, it's interesting because I remember you saying, actually, I can't remember which podcast it was on. I think it was a few different times. It might have been one of the lectures. You were talking about the frustration of it being easier to get antidepressants and antipsychotic drugs than even getting your testosterone checked. Like, is your view still the same on that?
Yeah, I'm probably less frustrated about it now and more just you accept it for what it is, as how corrupt and broken it is. But it's also about not moving into nihilism. There's like a sweet spot somewhere in between. I'm looking for that. But in terms of like when people identify with their disease state, like it's a very well observed psychological phenomenon. I'm not sure what it's called, but it's like it's becoming addicted to the attention of the outcome of when the victim mentality produces a return, and yeah, you see it a lot. And I think that I don't think people consciously want to stay sick, but I think people can definitely unconsciously become addicted to the attention that they get, especially in like a family dynamic when they're unwell. And I think that can be like an unhealthy mental health manifestation that, I'm not a psychologist, but I'm sure people can see, like, join the dots there and see that there's something going on. And the difficulty with that, though, is people don't realize they're doing it. And I think that's the problem. And I'm sure they wouldn't want to be doing it if they could see that they're doing it. But in terms of how easy it is to get the wrong treatment, I think that then just compounds that problem, or even it maybe even facilitates that problem in some ways, because especially in America, where people are marketed on TV and at baseball games and stuff, to be prescribed psychiatric medication, that to people from the UK and Australia, like when you go to the US and you see that for the first time, it's jarring. It's like, what? Yeah, it's like, what are you doing? And then after a few days, everything starts to make sense. You go, oh, this is what's causing a lot of these problems. And I think that even creates a culture that's kind of permeated through all of the West, through social media and the Americanization of the globe, through globalization, is that value of, I don't feel like something is the way I want it to be, so I'm going to go to my doctor and ask for a medication to fix that issue. I think that culturally has kind of become systemic. And the problem is that most of the time it doesn't work, and it almost always causes side effects. And that's I guess there's a lot of bad paths with false promises or idealistic outcomes that come from stopping doing the things you shouldn't be doing and starting doing the things you should be doing. And some people don't know what those things are, and then they need to be educated on that. And I've made lectures on that. I've gone through all that so people can really see what it is. But that's what I think at a macro level, a lot of this stuff is people are looking for a way around.
Yeah. And you mentioned the media there. You said about the media in that article with regard to the pharmacy, the compound pharmacy earlier, but I definitely see over here, there was an article recently that some journalist went around so many TRT clinics and was trying to pick holes at them. And then they had NHS doctors that were saying about it, like being, I personally feel it could potentially be overprescribed in a way that it's definitely not overprescribed on the NHS when we look at TRT. But if we actually look at how many people could potentially improve with the lifestyle interventions, that it may be overprescribed before they've done those things. which they're going to then see the side effects. But we're seeing the media just smashing TRT clinics so much at the moment. And I suppose as well with the overprescription side of things, and I don't know what your thoughts on being overprescribed, but I also feel things like GLP-1s are overprescribed, and that so many people could be doing the lifestyle interventions. And the same with TRT, as you've said so many times, that I'm putting a Ferrari engine in a Suzuki Swift, and I'd still love to see that. Maybe we should do like an AI. There must be an AI way of doing a video on that.
We should just do the real thing. I think that would be way more.
Yeah, exactly. Yeah, we can get that done. But it feels like it is being overprescribed, but the awareness of it is still, in my eyes, what I see with people that I work with. When I mention TRT, when I mention testosterone, it's still that it's steroids. Have you seen any change in that at all? That it not being seen as steroids?
It's kind of both, right? It's kind of like the under and overprescribed thing. And I'm very much probably in like a very echo chamber niche of the population for this. And I'm also very tuned out of a lot of social media and media in general. So, but also maybe I'm just optimistic with the way that I look at it. But I think it has to be seen by the average person less so as steroids because it's so much more mainstream. But then the question is, now that more people are aware of it, even if it is a small percentage, the more people think it's steroids. I don't care. I really don't care. And I think that's what a lot of it comes back to me for is that if you need a medical intervention, or and I'll talk about the second point of this in a minute, what someone else thinks about that is not important, especially if they're wrong. And I think that that's something that like people just need to tune out of and just, not really care too much. But yeah, I think the perception of that culturally has to be moving away a little bit from that because hormone replacement therapy is becoming more mainstream. I think probably like Joe Rogan being a champion for TRT was probably like a very big catalyst event in the timeline of it, looking back. The thing I think about the overprescribing, and I've been talking a lot about this in conversations with the various people that I'm working on these projects with, because I think because I've worked multiple clinics side for, I don't know, maybe 6 or 7 years now, and seen how this has kind of shaped and evolved and ebbed and flowed in different countries. My personal stance at the moment is, with everything we now know and understand about the reference range being nonsense and different men having different receptor density profiles, and also, at a certain age, testosterone will have declined by a certain point. It will have declined a certain degree from what a man was when he was at his peak. Regardless of what that level is at 50 or 60, it has declined.
Yep.
But with all these factors at play, like when you walk into the average clinic, and let's assume that they're a good clinic in this example, let's assume we found a unicorn. Whether they're operating from whatever guideline or whatever best practice approach, who are they to determine whether you can or can't have access to an optimal level of a bioidentical hormone that you should be making? And that's where I look at this and go, and I'm going to use female breast augmentation as an analogy here. There's probably better ones, but I think it's just one that it's just more enjoyable to envision, I guess, or people can put the two and two together better. But if a woman needs a mastectomy due to breast cancer, a breast removal, getting breast augmentation after that is often covered by insurance because it's deemed as important for mental health because it's restoring the balances of the body. That's not seen with the same stigma as a 25-year-old wanting big old titties. But it's the same operation. But in that instance, the woman who doesn't medically need it is still able to get it because she wants to get it. Now, the downside of breast augmentation is that a lot of the implants are toxic and long-term effects and blah, 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 blah. But the point there is that you've got a medically indicated intervention, but then you've also got an elective intervention. Except in this example, this doesn't actually lead to objectively better health outcomes. This is like basically a cosmetic thing. So if we move over to the TRT, I think it's giving someone an undue degree of power to say, there's a line here, And if you're below this, you can have it. But if you're just above it, you're not allowed it. Even though we know that that line is not that accurate. But this guy would still benefit from it. Maybe, let's say, a few percent less than this guy. But it would still be life-changing. He only gets one life. He only gets to be in his 30s, 40s, 50s, one. And as long as he's able to make informed consent, like that's the important part, to understand there's dependence, to understand it can complicate fertility, to understand that you have to get blood work, to understand that you have to be healthy and have health congruent lifestyle habits for it to produce good outcomes. You should inject it every day or use it topically twice a day, minimal 3 times a week for injections. Like, it's a bit of a commitment. But the juice is worth the squeeze. And if someone's sitting there, like if they've already got high testosterone, then no, they shouldn't go on TRT because you'd just be creating more work. But if someone's mid-range, I think they should be able to do it electively. So I think it's overprescribed in the sense that people are given it under false pretenses, or they have unrealistic expectations, or they're not making informed consent. But I also think there's a whole bunch of people where it's being underprescribed, where they would use it responsibly. They have every right to have a free testosterone level of 20, 30, 40% above the reference range because the reference range is sick. And if they're also recognizing that it's not destroying their lives, but it's still holding them back, and they're wanting to make that intervention to achieve that outcome, as a grown adult, if you can get a face tattoo, why can't you augment your testosterone levels? That's how I look.
Yeah, it's, and here in the NHS as well, in the UK, it's about 2 years roughly from initially going to the doctors, if you're lucky, to going to an endocrinologist, to then getting your test done, to see whether you actually get anything from it. It's another 2 years of, and then they will only really give you test libido. So it's a frustrating thing. But on that note as well, I'm sure it's a question that gets asked all the time. At what point do you feel that TRT becomes a steroid cycle?
Well, it becomes a steroid. Well, it's only a cycle if you stop.
Oh yeah, true. Steroid dose.
Yeah. So at what point does it become? Well, testosterone, bioidentical testosterone, can be classified as a steroid. So but it's not an anabolic steroid derivative. So again, it's all just semantics of language. But at what point does it become super physiological and therefore performance enhancing? And that point is going to be different for every person, because it would be physiological for a healthy athletic 21-year-old to have much higher levels than an 80-year-old diabetic alcoholic. So the physiological ceiling would be very different for both of those two as outliers. In terms of in the middle of that, for average Joe who's relatively healthy or very healthy, and let's say between 30 and 50 years old, I think it probably varies by, if we're going to talk total testosterone. Actually, no, let's talk free testosterone in, it's picomole per liter in Australia. What's the free testosterone range you use? It's just a move decimal.
Nanomoles.
Nanomoles, right? Okay, so we'll talk about it in nanomoles. So I would say that if someone's unhealthy, it becomes super physiological, probably beyond about a 1 nanomole per liter. If they're relatively healthy or in good health, it tends to become super physiological beyond somewhere around 1.2 to 1.5, maybe up to pushing a 2, depending on the guy. That's the point that I would personally theorize that it becomes super physiological. There's not a study that shows that. We don't have a consensus line on that, and people will disagree. That's the point that I see people start to produce symptoms that indicate that it's beyond the body's physiological tolerance, which is typically showing up in the autonomic nervous system. So blood pressure goes up, sweating goes up, sleep goes down, sleep is more broken. They tend to be the signals that you get. And then if they run it for too long, the blood work starts to go astray. But those are typically the things that show up. But it's somewhere around that level. And then for dose, that translates to a dose for most people between like 200 and 300 milligrams per week. It would cross into a super physiological amount. For unhealthy people, it would be a bit lower.
With that as well, I don't know, like here in the UK, we have like BSSM guidelines to follow, like the British Society of Sexual Medicine. How do you push that within a clinic? Like, and this is like using this, like asking, I had the question in the group saying about, it was actually 16 milligrams I was using. Basically my total testosterone was at like 21. So I pushed it up to 20, and free testosterone went from like 0.58 to literally 1.01. Total testosterone went up to 38.4. So
Yeah, so
the
that's an
doctor then,
average response. Yeah.
yeah, like, and I felt good at that level. And then the doctor also then saw my hematocrit go from 48.48 to 0.52. And this is over 6 months. And it's like, you need to go back down to 16 because you're out of that range. How do we justify that? Because when I sign up to a doctor, like, I get frustrated when clients don't do the things that I say that they should do. So I'm paying for this advice, shall we say, but I'm not able to stay at those levels, especially when they have to clinically stay within guidelines. How do you navigate that, maybe as a clinic and then as a conversation with a doctor?
The part that I struggle with this on, in terms of not coming across disrespectful to doctors at large, is that I guess I've seen so many doctors in terms of having them work in clinics that I work with, or I see their patients after them because their patient is unwell. And then as a client, I identify the issue and fix it and send them to a better provider. I would say that I can count on my fingers and toes the amount of competent doctors I've met, and I've met hundreds. And many of them, so like, let's say if I get, because the hematocrit reference range you're talking about there is incredibly low, because I've noticed in the UK that the reference range for hematocrit only goes up to 50. I don't know if this is
0.52 here.
Oh, 0.52. Well, congratulations.
Yeah.
In some places, it only goes up to 50.
Mine was at 0.527.
Right, so it goes to 3 decimal places. I've seen some hematocrit reference ranges that aren't gender adjusted. Like that happens. I've seen sometimes in Europe, they'll print female references for male hormones even. But the thing that I've always found baffling is that, so if you go to different brands of labs in a country, they'll have different reference ranges, because the reference ranges are not based on a universal central range. They're calculated independently by the lab, so they'll differ. They'll even sometimes differ from laboratory to laboratory within the same brand. And I see ranges from all over the world, but even just all over Australia, and they're all over the place. But what's interesting, and I've seen this with multiple doctors, and if any doctor denies that their colleagues do this, they're lying, is you'll have one lab test with a hematocrit of reference range up to, let's say, 54, and then another one where the reference range goes up to 52. And then you'll have a bunch of guys come in with a hematocrit of 53. And if it shows up bold and in red because they've got the low range, the doctor will say it's a problem. If it shows up not bold and not in red because they get the high range, the doctor won't flag it. And this happens all the time, not just with hematocrit, but I've seen it happen with lipids, especially with triglycerides. LDL, the top of the ranges, can vary drastically. And the doctor's recommendation or flagging it as a concern will have nothing to do with the actual number itself. It will have to do with whether it's bold and in red. And this is because many doctors do not intrinsically understand the meaning of the numbers that they're looking at, because they're spread too thin across too many things, or they're lazy. The problem with doctors, and it's the same for every profession, so I'm not going after doctors, I'm just taking them off their pedestal, is that the person who graduates at the bottom of medical school is still called doctor. So just like there are terrible accountants who still have a degree, there are terrible engineers, there are terrible teachers, and there are terrible doctors. And sadly, a lot of the doctors in the UK aren't very good, especially the standard ones that people would be going to as general practitioners. Now, there are good ones if you find them, but there's also good mechanics if you can find them. But walking into the average mechanic's office and just expecting everything to be great, trustworthy, honest service, maybe you're new to having a car. So, that's, how do you deal with that? How do you navigate that? There's a couple of things. So I would find it interesting to have a conversation with a doctor to ask them and say, if we can clearly show over the last few years that the testosterone reference range is drastically lowering, what's the substantiation for this changing the practice of care for hormone replacement therapy? If we're simply observing that the average population of people who aren't on hormone replacement therapy are declining for whatever reason, why would this change the way that we correct hormone replacement therapy which is a practice that's been done for multiple years, even decades. So it just doesn't make any sense. And the problem that you guys have with the NHS and all the regulations in the UK is that they seem a lot stricter than in any other country. Actually, no, Canada is very strict as well. Canada, New Zealand, and the UK have very, very strict guidelines. So the only way that it can be deviated outside the guidelines, as far as I'm aware, I'm not sure specifically with the UK, but the way that it works in all other countries is that it's basically a private off-label prescription. And it's recognizing that the patient requires higher levels than the average reference range to achieve physiological symptom outcomes and is well tolerated. Sometimes there can be a statement that the patient needs to sign to recognize that they're using something that's outside of the, in Australia, it would be the PBS. So in the UK, it would be the NHS. But the issue in the UK is that if men are confined to the reference range for their treatment, they're not going to be able to achieve resolution, because I wrote in my book quite a few years ago, and I stand by this, very few men will achieve any degree of symptom resolution with a free testosterone below a 0.6 nanomole per liter. Like that's the flaw. Most men need to be at least a 0.8, if not a 1 to 1.2. And if men are not able to do that, and like a hematocrit of 52 is perfectly healthy and normal, because when you go on TRT, you get usually a 1 to 2 point increase in hematocrit, maybe a 3 point increase, due to the therapeutic increase in red blood cells, because you're transporting oxygen to the cell, like it's working properly. The issue is that you can also get a few point increases from metabolic syndrome, smoking cigarettes, sleep apnea, stuff that's problematic. So when you sandwich those two things together, you can get a problem. But unless you're an endurance athlete, your hematocrit is going to be 50, 51, 52 on TRT. And that's not even controversial that it's healthy. Like, once it starts getting up to like 54, 55, 56, that's when like there can be debate about being like, is this a problem? I still don't think you phlebotomize at that point. I think you correct the root cause. But at that point, it starts to be, okay, this is where it starts to get symptomatic, and you're not going to die, but it's like it starts to get symptomatic here and it should be addressed. But lowering the dose based on a 52, and respectfully to the doctor, demonstrates no intrinsic understanding of testosterone replacement therapy, because that's absurd.
I have interest, actually, just thinking out loud. I don't think it would have a massive impact, but what about if you had surgery recovery? I had gynecomastia surgery on the 14th of April and my bloods were drawn on the 15th of May. Would recovering from that make much of a difference? I'm literally like just throwing that, thinking completely out loud. I don't think it would make masses of difference.
Probably. I mean, it could. I just, that far out after surgery, I wouldn't know if it would, because if you got it done like straight after surgery, hematocrit would be low due to blood loss. Exactly. But a month afterwards, depending on how much inflammation was still present, could that be driving it up? Maybe. But if it's a 52, I wouldn't even call it up.
Yeah. I've just literally just thrown that one out there. Like, what should we be looking at health-wise? Because we've mentioned about, you said about symptoms actually, but we've mentioned more about lab ranges. I always want people to have symptom resolution as well. But if people are pushing higher to get that symptom resolution, hematocrit we've mentioned, if it gets like 54, then have a look at it a little bit different. But health-wise, when pushing your dose higher to resolve symptoms, I don't really feel that pushing your dose higher just to get more muscle or more testosterone, if you've got symptom resolution, is a good thing. That's where the talk of steroids comes. But what should we be looking out for when we go to push higher?
The thing is that, if people are using things like equipoise or other anabolic steroids that drive up red blood cells more, then if they take high doses, you can push hematocrit way up 100%. I've seen people who've, haven't been working with me, but I've seen labs where people have gone like 61, 62 with equipoise. But with that said, I've never really seen someone induce a problematic hematocrit. Like hematocrit doesn't continue to rise in a linear fashion when you put the dose too high. That just doesn't happen. And a lot of the time when these doctors cut the dose down, it doesn't come down either. Because as long as it's still within a therapeutic range, it seems to add a few, again, 1, 2, maybe 3 points therapeutically, but it doesn't continue to add those points as you go up. It's really a lifestyle thing. and it's if your dose and your lifestyle are not congruent. So the stuff to look out for in terms of, do you mean lab markers to look out for if you take it too high?
Well, maybe changes in lab markers. I know if you're bumping your testosterone up, your estrogen is going to go up, like, or estradiol is going to go up
Yeah.
relatively, right?
It in the levels that you're talking about in terms of taking it up from where you're at, yeah.
It's not going to go up
Um,
massively.
but it won't go up massively, but there seems to be a certain point where it either stops climbing at the same rate or the testosterone leaves it behind in a lot of cases. But yeah, the testosterone and estrogen within the physiological TRT range, which is, top half the range to about double the top of the range, will usually climb pretty much in parallel, in tandem. And then at some point, if you're healthy, yeah, the testosterone will often leave the estrogen behind, but they'll climb in tandem because it's a primary metabolite. It's only when people are unhealthy metabolically or drinking too much alcohol or doing other things that induce aromatase that ratio will go massively in favor of the estrogen. But they'll feel that symptomatically before it comes up on the labs. The stuff that will start to take a bit of a twist in the labs, the autonomic symptoms will show up first. So like the sweating after eating, night sweats, broken sleep, high blood pressure, that kind of stuff, water retention, feeling of like your head's got a lot of pressure in it. But in terms of lab symptoms, your HDL goes down. That's one that will just kind of go, like it won't drop until you go super physiological, and then it will drop. Liver enzymes will start to climb as well, and this is where it's important to have consistent liver enzyme results after rest from training, because AST and ALT will just uptick like a hockey stick kind of uptick. They're the two big ones that you see. So it's those two and the combination of the autonomic nervous system markers. It's when you add in other anabolic steroids that you start to get more blood work issues. But that's less so coming from the total antigen load and more so coming from the non-bioidentical antigens themselves. But again, that's when people are pushing into different tiers of dosing.
Yeah, that's going into the bodybuilding world and shall we say, as we said, steroids as such. And on that note as well, that I think it's important to note that when you're with a clinic and they do their monitoring bloods, we need a good panel to actually do monitoring, right? We can't just have like 4 or 5 like testosterone free, testosterone album, SHBG or something like that, right? We have to hopefully get a full panel to check these things.
Yeah, hopefully. Typically, a clinic will just run the bloods needed to tick a box because medical providers have a duty of care. So if you run a bunch of blood tests and there's a bunch of problems, you're now responsible for fixing the problems. So it's much less work if a clinic just runs the bloods that ticks the box, and then that's typically a sex hormone panel and a red blood cell count. That's typically what it is. And a lot of the time, there's not even a free testosterone on there because they don't understand what they're doing. So yeah, that kind of blood test, all that blood test is going to tell you is how much testosterone you're taking. That's all it does. It's useless. So when it comes to optimizing testosterone, the limitation is, and this is where testosterone's harder than stuff like thyroid, but thyroid's difficult in other ways, is like, do you need your free testosterone to be like, 0.6, 0.7, 0.8, or do you need it to be like 1.2, 1.3, 1.4, like, or somewhere in the middle? That's a big goalpost range. Like that's as big of a range as 0 to starting to be optimal. Like that's a big range. So you're not going to know where you need to be in that range just based on testing the testosterone level. You have to test the rest of the blood markers to get all the different feedback systems from the body to basically ascertain, are you objectively healthier as a biological organism since taking your testosterone levels to this than you were before you started? And if not, why not? What's wrong? And what needs to be fixed to correct this issue? And usually it's something else causing a problem that the testosterone is highlighting. So there has to be a comprehensive panel, but at the same time, like if you get the best panel in the world done, the average doctor's not going to know what they're looking at, so it's not going to help. So the strength of the panel is a determining red or green flag as to whether the provider knows what they're doing or actually cares. It's not a solution to take a bad provider, a good panel, because it will be like, taking someone who speaks English something in Chinese. They're just not going to be able to.
Yeah, that makes sense. Let's dive into different types of TRT administration methods, shall we say. So you've said previously about gels not being very optimal at all, especially like cream and test sip being pretty much the gold standard, right? And not Nebido. What about Kaisertrex as the oral medication?
I'll quickly touch on Nebido because, and I'll just quickly give a clarifier as well. I think test sip and test ananthate are basically interchangeable for all intended purposes. And for people in the UK or people in Europe who can only get sustanon, if that's done daily, I'd say it's for all intended purposes interchangeable as well with cypionate and ananthate. So don't fret if you're not using exactly cypionate. Now, when it comes to Nebido, or in other countries it's called Reandron, which is testosterone undecanoate, which interestingly is the injectable version that Kaisertrex is orally. This has come up to end of patent. So we're now at a point that a compounding pharmacy would be able to make this. It wouldn't need to be prescribed as Nebido or Reandron. It could be prescribed by a clinic. Now, the advantage of this is we've now got a really long-acting ester. So we can be like, well, maybe I can do less frequent injections, like let's say weekly or twice a week, and maybe that would give me levels equivalent to every other day to daily injections. Maybe. That's where I think things need to be looked at. The problem is, at the moment, they say that it peaks at 1 week. That's because that was the first interval they looked at it. They didn't look at it on days 1 through 6. They looked at it at day 7, 14, 21, and so on. So if it turned out that it in fact peaked at a week, then a twice weekly injection of that would be probably equatable to daily injections. And a weekly injection would be probably equatable to every other day. So that would be extremely exciting, and it would also be cost comparable. So for people, especially doing shift work or young parents and stuff like that, that could be cool. That's what I think could be on the horizon soon. Kaisertrex is a very interesting product. So when I first started treatment, I was given andriol testo caps. This was before I knew what I was doing. Anyone really knew what they were doing, which is the same thing as Kaisertrex. It's engineered a little bit more poorly. Kaisertrex is made much better, but it's a much lower dose. So naturally, it didn't work at all. I mean, I think I had lower levels on that than before I started. But Kaisertrex is an interesting product. So I met Charlene, who's their CEO at the Silverback Summit a few years back now. I think we'd be looking 3 years back. And we met at like a social mixer. And I was very blunt. I was like, I don't think oral testosterone is any good. I think it's a waste of time. And he was like, can I explain to you why we wouldn't agree? And I'm like, absolutely. So I think we sat down for about 90 minutes and he took me through everything. And at the end of it, I could see the use case for it. I then kind of waited since then till about 6 months ago to see how it played out. Like, I never recommended it. I never dissuaded people, but I just saw people come to me on it a lot. And after enough people came to me on it, I could see what the point of it was. Like, I had a light bulb moment and I understood it. And the thing I like about Charlene and the Kaisertrex company, Marius Pharmaceuticals, who do not pay me to say nice things about them, small pharma and big pharma are not the same thing, is they understand that they're a tool in the toolbox. And they're not trying to replace cream or injections. They're broadening the horizon of the treatment. But I think that's where it's important to kind of get into, like, what does it do and who is it for or who is it not for?
Yeah, I think like Charlene, he was on the podcast a couple of episodes ago, and I got the same kind of feeling that, again, it's an additional tool in the toolbox for people there. And I've seen as well, and it's only been a couple of people I've seen their blood work from using it. And one of them was actually switching from test Nebido anyway. And like, his test Nebido was tested 4 weeks after injection. So he was getting every 10, 11 weeks injections, and it was like a gram of testosterone going in. And it was about 35 nanomoles a liter. I can't remember the exact numbers. But then when we tested the day after well, he had his oral morning and evening with the Kaisertrex. It was at like 22 nanomoles a liter. So it wasn't, and that's only just starting. So again, maybe it could be the dose that needs changing, but then the cost goes up as well, right? So are you seeing lowered bloods as well, like or blood levels of testosterone?
I see it as being for people who only need their levels there. So older people, people with concurrent medical conditions. That's where I see the limitation. And I think that Marius see it, and again, I don't want to speak for the company, but they see that as a feature, not a bug. And that's what I like about the product. And the thing I like the most about the idea of Kaisertrex, once I saw it play out, is that like if we took this like individual and let's say hypothetically they just started on Kaisertrex, they didn't do the libido beforehand. Let's say that their starting testosterone was 8 and it got them to a 22. Because the Kaisertrex is not suppressing the natural production, it causes a little bit of transient suppression when it's peaking, but it doesn't suppress the actual axis. That's your way potentially of saying, let's try testosterone therapy. Let's see if this is the thing that makes me feel better. So when people are using things like Clomid and clomiphene for that at the moment, they should be using Kaisertrex. And then the advantage of that is like almost a stepping stone. And this isn't what Charlene would be promoting it for. This is how I look at it in terms of like, this is my toolbox. I use everything. It's being like, okay, if that got you from 8 to 22 and you're like, I feel a bit better, but I want to feel like, you take it to a higher level and see if there's more on the table. Cool. Injections and cream. But if someone's like, I feel fantastic, this is excellent. Or if they're like, we're not looking to conceive right now, but we're looking to have a kid in the next year or two, and I don't want to potentially have to do a fertility protocol treatment, and this is good enough to get me through until then, great. But for all the men who are like my father's age, guys who are, age-related hormone decline or even a bit older, like grandparents, like you don't have to, if there's a bit of a tremor, injections are out. Cream schedule can be cumbersome, but pill every morning, like this just opened the door to so many more people being able to access the benefits of testosterone. And that sounds like a sales pitch for them, but it's when I talked to Charlene about it, like I called him when I was in Amsterdam a few months ago, out of the blue, and I was like, I finally get it. Like I get your product. It took me like 2 years, but I'm like, this is about widening the scope of people who could benefit from testosterone.
Yeah. What about your thoughts? I mean, they say 1 dose or 2 doses a day. What, 1 pill twice a day? What about adding a third in, like middle of the day? Like again, consistency is going to be the key thing, whether you can do it, right? Would that help? Do you think? Because it's a 5-hour half-life, is it?
I believe, and I could be wrong, but I believe their guideline recommendation is morning and noon or afternoon, as opposed to morning, noon, and bedtime. And the interesting thing is that when you give guys cream, some guys find it helps their sleep, and some guys find it makes it worse. And I think the idea of avoiding the evening dose means that you're not going to make the sleep worse. I just think that it would be, and I agree with you in terms of the 3 times a day dosing, is that then you get more stability, and then you also get a scenario where the testosterone is supporting recovery. And that's when testosterone naturally peaks, is in the early hours of the morning as well. So there must be some circadian processes tied to not being hypergonadal at that point. I guess the way that you can get away with it having a shorter half-life, and this is what I asked it, because I went through all their research because I wanted to understand it. I believe, and again, I may have interpreted it wrong because I didn't get a chance to go through it with that team, but I believe that the premise is that, let's say you're using testosterone propionate for HRT, and you're going like, let's say you're doing it like stupidly, like twice a week or something. So you'd peak up and you'd crash down, and then you'd peak up and you'd crash down. But when you'd be crashing down at like zilcho. The idea here is that if it has a short half-life, you'd be settling back to your baseline. You wouldn't be crashing. So the idea is, because the way that when we look at hormones, you've got the acute effect at the receptor, but you've also got a downstream transcriptional effect. So, for example, thyroid therapy with T3 isn't elevated for 24 hours. It's typically given in a pulsatile fashion. Now, I would argue that reducing those pulses at least a little bit and having it more steady is probably a good idea. But we know that we can get resolution of hypothyroidism even with pulses because the baseline level is still there. It's not pulsing to zero. But that transient elevation will still carry through an effect for longer than the amount of time that that peak is occurring. It's kind of like when you press the button, it doesn't just shut off when you stop putting the pressure on. The button stays pressed for a while. So that's the premise that they have, is that you're not crashing down, but you're building on top of your baseline, and that peak effect will be able to carry through for longer. And the fact that peak is not going as high means that you can have that peak and not get the side effects of injections where the peak can cause overconversion to different ratios of metabolites like estradiol. I think that's my understanding of it.
That makes sense. That makes sense to me. I don't know if everyone else got a sense of that, because I'm able to actually watch you going into your hand movements as well. So if people haven't seen it, watch the video and see Dave's explanation and also the movements going through it as well. So touching on the bodybuilding world, right? That's where I'm from. I used to compete in bodybuilding. I'd say it was like 2012, the last show. So that was a lifetime ago. But a lot of my friends are still in that world, and they're still blasting and cruising, and they do the cruises to try and negate what I would say is the damage caused by the blasts. And I personally feel like when I competed, I was like 72 kilos, and there was about 3 or 4 cycles of steroids afterwards. And like the last time I actually done that, tried to come off in 2015, and then 2016 is when I really started the TRT side of things. My testosterone hasn't been high at that point. Highest it's been is actually the 38.4. That was with the 20 milligrams a day recently. And I feel I've put on more muscle. Like I'm like 94 kilos now and feeling really great shape. The first time I felt comfortable in my skin for a long, long while. And even better, now I've shaved my head, which was, again, like it was the right thing to do. But do you see any long-term damage, like with people still doing things like blast and cruise?
I think it's fascinating. I think bodybuilding is fascinating. I don't like bodybuilding. Like I'm not into it.
I don't like it anymore.
But I think they're fascinating people, and especially with pushing the pharmacology for like to me. I don't know, looking at it from the outside, I'm like, this is an insane squeeze for not a lot of juice. But they're fascinating to learn from. And the premise of blasting and cruising, it never made a lot of sense to me from, again, I wasn't sure about if blasting and cruise makes sense from like a pulsing training styles and whatever. But from a health standpoint, to me, it would be like, if you do something bad for a period, if you then don't do something bad for, a period after that, it's not going to undo the damage that you did during the bad period. Like if you binge drink and eat garbage Saturday, Sunday, but then you eat clean and train Monday to Friday, it doesn't undo Saturday and Sunday. It might mitigate some of the issue. It's better than doing what you were doing on Saturday and Sunday all the way through the week. But it's not going to undo it. And I think it can be wishful thinking. But I also know that there are people who do the health mitigation and prevention of those side effects much, much better than others. People like Dr. Todd Lee, people like Vigorous Steve. I watch the videos where Steve puts up his blood work like on cycle with his like ancillary support, and all his blood markers look like he's on nothing. And he's an endurance athlete. Like they look amazing. I do wonder how much of that is just blood work manipulation as opposed to actually preventing the issue from occurring. But I have seen that, a lot of these guys, they have clear coronary artery scan reports. And I think that there's probably a lot of variables beyond just blasting the anabolics that are a problem. And that's where I'll kind of give the devil's advocate is that, if you give me 100 guys who are blasting and cruising, some of them are eating clean, getting enough sleep, hydrating properly, managing their blood pressure, taking healthy supplements, doing all the health promoting lifestyle habits, and like living clean. Um, Other guys are not. And then you've also got like, well, what are they blasting? You know, you might have one guy who's like strictly just used like, Masteron and Primobolan, for example. And then another guy who's just taken a whole bunch of like oral liver toxic steroids and all of this. And so it's a big mix. And I think it can be done in a way that is much less dangerous. Like I think people can do stuff to mitigate it and still like I think that if you kind of took someone who dialed all that stuff in and didn't, I think that the guy could probably take double the amount of gear that the guy who didn't have it dialed in and probably have less damage. So I think you can mitigate it within a sense. The way that I would look at it though is I don't think there's a way to do it that's 100% safe. Like I don't think that there's a blasting and cruising protocol that would mitigate 100% of the damage. I think there are varying amounts you can mitigate, but I think at the end of the day, there's always going to be damage occurring. But I also think that some guys they're like, I know, like they know, and they're like, I'm just trading years off at the back end, and I respect that. Like that's up to you if that's informed consent what you want to do. I just think the risk can sometimes be maybe that risk will pop up sooner than you thought it would if you're continuing to kind of push it. So, I think if people are going to do it, they should just invest in their health, be on top of their blood work, look at these things, accept that there's going to be some risk, and then use the most risk mitigating stuff and approach, but then still understand that there will be some risk there. But there's also risk in, having a couple of drinks on a Friday night or getting in a car every morning. So, it's kind of up to them.
Yeah. There's something actually going on to that is someone that I'd bridged a couple of cycles together and said it was blast and cruise. I think it was also the psychological aspect of like, you've pushed so hard and you felt kind of superhuman, but then the impact of having super physiological levels of testosterone and other things in the system gave you extra anxiety. So then you were so worried about coming off, you would be like, I can just go on this bridge level, this cruise level, so I don't have to drop the levels, rather than going up and then wait for your levels to come back. And I think that was a psychological aspect. What about the extra muscle that it brings as well? Because I don't feel massive, and some people say like you look bigger than the average person. I'm like, I don't even feel like I lift sometimes. Bit of body dysmorphia going on all the time.
Like, you absolutely look like you live.
Yeah, well, like this is a good angle, but BMI is 32, right? So, which frustrates me when I try for like health insurance. They're like, we'll give you a 10% discount if you lose 30 kilos. I'm like, where am I going to lose 30 kilos from? Like 94 kilos and 172 centimeters. It's that's still going to be, I don't want to be 100 kilos, 105, 110 kilos, because it's all extra pressure on a system that is carrying a little bit extra muscle. I always say that people should be able to run for like 10K. It may not be, it's definitely not pretty when I run 10K, and it's not fast. 30-minute 5K, but I can do it. I'm not going to gas out. If my daughter is very much like an emergency, I need to get to her.
Completely agree.
And I think like again, any other variable, like we've touched on blood tests for more the testosterone side of things, but any other variables of like putting that extra pressure on your system with extra muscle, any variables we need to look at?
Yeah, like so before I put my back out when some dog attacked my puppy and then I threw the dog off him while in a full squat, my dog was fine, my back was fine. So up until that point, I was really into lifting heavy. So I got up to 120, not lean, but strong. And I loved the strength that came with that. Like it wasn't about, how big and muscly and ripped I looked. It was just like, I liked being big and strong. And the psychological aspect of being big and strong, I liked too. But it was the first time I started snoring. I think that, I don't know where the tipping point was, but it was between 110 and 120. And I started snoring, and cardio got real difficult. And I wasn't on anything beyond TRT, but I just had the goal of putting on weight and getting big and strong. And the thing that people need to look at when they're going higher is the blood pressure and the sleep apnea. That's the two. Because at some point, whether it's muscle, fat, or both, you can get this at fucking 8% body fat if you're a mass monster. You will eventually put too much pressure on your windpipe when you're sleeping, and it will obstruct, and you'll need a CPAP. That was the point that I just immediately started cutting weight because I'm not doing this. And it's the blood pressure as well. And there's some interesting conflicting schools of thought on this. And I'm usually an anti-pharmaceutical guy, but if someone is overweight and hypertensive, or they've just pushed it too far with bulking and training, like, doesn't matter how you got there, I think you're better off managing the blood pressure until the blood pressure medication is no longer needed, because you'll feel better, and it might take you a while to get back on track. You think you'll be there in 6 months, but it might take 6 years. But yeah, blood pressure and sleep apnea are the two big things people need to watch as they're getting heavier. And then also they need to monitor their HbA1c, because if you put on too much body fat, beyond 15% body fat, you'll become varying degrees of insulin resistant. And there's likely a genetic component in terms of how much you can get away with. And when you become insulin resistant, it can make weight loss more difficult, which is why it's not that much easier to lose weight. The fatter you are, it can actually be harder. But that's when I lean on things like metformin rather than GLP-1s. But that's when some kind of potential intervention could be short-term, warranted, until it's no longer needed. And that's where I think it's lifestyle first, ancillaries to act as a short-term crutch to get you to where you need to go, and then get, using only the safest and best ancillaries and then getting on.
That makes sense. And that leads us on to a couple more questions. TRT supplements, or supplements when on TRT, what would you say are some vital supplements? I mean, I suppose some of them are going to just be general health supplements that we know about anyway, but especially when you get onto TRT, these are really going to help you for your general health.
Yeah, I think that supplementing is worth doing. It can also be a waste of time, and you can also waste a bunch of money. But I think doing something simple is better than doing nothing. I used to be more of a get it all from food, you don't need multivitamins kind of guy. And everyone that I know as my colleagues who were in that camp, we've all gone to the multivitamin side of the fence, because they make a difference. In, like, when you're working with people clinically, they are the most useful thing in the world. It just needs to be a really fucking good quality one, and most of them are garbage. The best standard. So firstly, I'll plug it. I have a AM PM supplement pack coming out with my friends at Victory Men's Health, because I basically asked this question and put them into packs for people. But
US based, right?
US based, yeah. It'll be on Amazon.
Yeah.
But I'll break it. It's got like a open label, so I'll break it down for people in terms of how I'd put it together individually. The first thing I will say is that this is like 4 to 5 supplements, and some people are like, I'm not taking that many things. I take more than 5. I don't think 5's a lot, but some people, they're like, I'm not doing the same. If someone's in that camp, that's cool. There's a product by a brand called Life Extension. You can get it everywhere, and it's called Comprehensive Nutrient Packs. It's a daily pack. It sounds like an ad. If they want to send me some money, that'd be cool. I don't sell it. But it's a good multivitamin. It's 2 soft gels of fish oil that won't go rancid. It's some CoQ10 ubiquinol, which is really good for the heart. Some trace minerals, some really good quality curcumin, and then a mix of nice things like blended form of vitamin E, a high dose of vitamin K2, some other polyphenols and other nutrients to support eye health. It's just a nice mix of, it's not everything, but if someone's like, I only want to take one thing, that is so much better than any other one thing that you can get. So that 100%, I give that to my parents. And I use it as well, until my victory packs get here. Now, if people want to kind of put together something themselves, it's a bit more TRT focused. The multivitamin's still the foundation. I would use the Thorne Basic Nutrients product. It's just got a bit more vitamin D than it's a little bit different to the Life Extension one. It's just slightly better. And then you can split it up AM, PM. But the Life Extension one's fine. I would then add magnesium. Now, testosterone depletes magnesium a little bit faster, so you have a higher requirement for it. The idea that everyone's deficient in magnesium is a marketing ploy, but most people can benefit from more magnesium. So it's kind of both. So on TRT, you can really benefit from higher doses of magnesium. So I recommend 200 to 400 milligrams twice a day. So that would be a total of 400 to 800 milligrams a day. So 400 at the bottom end, 800 at the top end. You could push higher if you wanted to. But of magnesium glycinate. There's a brand called Doctor's Best. You get like 240 tablets in a bottle for like $20. Good quality. That'd last you a month at 800 milligrams. The next one I add in is vitamin D. Pretty much everyone in the UK is vitamin D deficient. Even people in sunnier countries can be vitamin D deficient because the sun is harsher. So vitamin D is very important, not just for testosterone, but for thyroid receptors as well. The dosing RDA was recalculated. It's 1 decimal place off. So for men, it's 600. This was reviewed in a study that I think it's 5 years old, maybe 6, 7 years old. And it's actually meant to be just over 6,000 IU is what the RDA is meant to be. So 5 to 10,000 units of vitamin D. The multivitamin or the comprehensive pack covers off the vitamin K to go with it. And the last one is omega-3 fish oil. Some people are concerned that fish oil is rancid and oxidized. Cheap, crappy ones might be, but get a good quality one, and that's not an issue. I use the Sports Research brand. Again, I don't have any affiliation with any of these. And you get a gram of EPA and DHA per soft gel. Usually, fish oil is really, really weak, so you only get maybe 200 or 300 milligrams per soft gel of the actual EPA, DHA. And to get the clinical outcomes that you get from bringing your omega-3 index to like 8 to 12%, you want to be using 2 to 4 grams of combined EPA, DHA per day, which is really only the equivalent of eating about 200 grams of salmon a day, maybe a bit more. But it is much more than what you get from typical omega-3 supplements. And if you add all that stuff in, what you're doing is you're giving your body like a robust pool of all the essential nutrients it needs to do the stuff that testosterone is telling it to do. And out of all the supplements you can take that are trying to push your body in a certain direction, you just give it the nutritional foundations in bioavailable forms. You give it an abundance of these nutrients so that it's not stressed. And then you particularly lean into the ones that testosterone either synergizes with or creates a higher demand for, which is magnesium and vitamin.
I think it's important, as we say, I take a lot of different supplements, and some of them you notice a difference when you put them in. And I want to be on a foundational level of as minimal supplements as possible. But I see people spending the better their lifestyle is, the less supplements they should ideally need to take. And I've seen people as well tell me, taking like 800 milligrams of magnesium, that's excessive. I'm like, having a bottle of wine a night is excessive. And they don't see that, or they're worried about it, and you're not worried about the alcohol you're taking. But anyway, just last 2 questions here, and quicker ones. But if there's one lecture of yours that guys should listen to that you really recommend, what would that be?
The first Your Brain on Testosterone and War on Masculinity lecture. I just re-recorded it a couple of months ago, so it's out of my channel. If you just search Your Brain on Testosterone Dave Lee, it'll come up. That is a 3-part, kind of 4-part, 3-part lecture series. It's worth watching all 3, but that first one was my friend Ali Gilbert, when she put on the Silverback Summit. She gave me my first speaking opportunity in this industry, and she was like, you can speak about whatever you want. And I was like, okay. And that was kind of the first time I think anyone had really spoken about bringing together all the environmental hormone disruption, the impacts of testosterone and how it works in the brain and how it works with behavior, and then kind of masculinity and lifestyle and bringing it all together. That's the one that the most people have told me has been like really impactful on their lives.
Yeah, I did like that. I don't know if I listened to the 3rd and 4th parts, but the 1st and 2nd ones I've definitely.
The 3rd and 4th are live, so they're on my YouTube channel. Okay. They're at the Silverback Summit in Austin, Texas is part 3, and then part 4 is the keynote from the year later. So they're live speaking.
or like 20, 24, did you? And I think I've seen on there. So yeah. So cool. And I asked you this in the Q&A a couple days ago, and I like the answer, but also I noticed it got asked again in another Q&A literally like yesterday. But TRT is pretty much, in my eyes, it's gone mainstream, which I feel is a good thing, apart from the media pushback that seems to be happening. But we've seen guys get absolutely amazing life-changing results. Like, what do you feel the future of TRT looks like?
It was interesting when people asked me that when I first entered the industry, and this was right around when COVID was kicking off. And I remember saying to people, well, it's either going to get worse or better, but it's definitely not going to stay the same. I think it got both. It became a household term, like, because I've been working in this field for so long now. Like, if I used to say to people I work with TRT, and everyone would just be like, "What is that?" Now almost everyone knows what it is. But at the same time, especially in the US, it's been, but also now in Australia, the UK, all over the world, the industry is primarily dominated by bad faith players. And then you've also got very difficult government bureaucracy. So you've got a lot of people they're seeing a reoccurring business model with massive profit margins and not just reoccurring subscriptions, but physiological dependency. Very minimal cost of goods sold and massive, massive, massive margins and huge perception of value. So there's a lot of people who are in the industry now or who are coming in, especially after they heard that pitch, who are looking at this as a business opportunity. And as a result, the standard of care is now lower than what it was when I entered the industry five years ago professionally, when I started doing this full time. The standard of care was better back then than it is now. And yeah, combine that with you've got a small handful of people who are trying to do the right thing, but are being so heavily scrutinized and regulated by government authorities that clearly do not want men to be happy, strong, and healthy and having good, positive family dynamics. It makes it very difficult, but I don't know, you give the male population their testosterone back, like that's going to be a fucking movement. Like it has to be, because you're giving males their life force back that you took from them. So despite all of these issues, it will continue to grow with inertia because it has to. Eventually, I think it's going to get to a point that it's going to be quite heavily regulated, like what's happening with peptide. I think that some good will come from that, but I think it's also going to push a lot of it into the underground, because a lot of people will not want to comply with the regulations that come in, and therefore there'll be a big underground industry for it. I think that's what it will look like. But I'm more excited about what it will look like in terms of treatments. Because I think in 10 years' time, like if you look back 10 years ago, Dr. John Chrysler, actually, was it 10 years ago? 15 years ago. 17 years ago. 2009, Dr. John Chrysler wrote an amazing publication. And the reason why it's amazing is if you look at it now, he was the thought leader at the time, and he was talking about how incredibly progressive it was to use things like testosterone gels, like Testogel, to incorporate things like sublingual pregnenolone DHEA, adding in HCG for the first time with weekly testosterone injections. Like all of this stuff was groundbreaking back then. So if we look at 15, 17 years down the road in the future, we'll probably look back on what we're doing now and being like, that was, very old fashioned. So how it's going to evolve, I think, is really exciting. I think that products like Kaisertrex will be a big player because they will also allow women to take their full HRT regimen orally, which is really exciting for women. I think injectable testosterone will still stick around as the tried and true because it will just remain the gold standard. But I think longer esters will be definitely a part of it. And I think that the availability and improvements in the technology of cream as well, I think that will continue to progress. And I'd say that, my prediction is in 10 or 15 years' time, there'll probably be an even split between like oral testosterone products that are good, like evolutions of Kaisertrex as well, topicals, more advanced topicals, and longer acting injectables. And I think it'll be a more diversified treatment population, which is why there will be more diversified treatment.
That sounds an exciting future there. And just lastly, I think you recommended Ali Gilbert last time, so I need to actually reach out to her. I keep forgetting to do that, but anyone else you would recommend to come on the podcast to chat men's health?
Well, I think there is an enormous benefit in doing an episode to chat about women's hormonal health, because I get questions all the time, which is like, who can I see for my wife and my girlfriend? Well, usually it's wife or girlfriend, not maybe wife and girlfriend.
Yeah.
But there's a lady named Dr. Lauren, Dr. Fitz, Dr. Lauren out of the States. She's very high level for both men and women for HRT. So, and she's an anesthetist. So she's great. She's a great educator. She'd be great to have on, because it's great for guys to know where their partners can start in terms of being like, what's the first step to take, or what's the similarities and differences, or like, what does it even look like for women? Like all that kind of stuff I think is really interesting. But yeah, Ali's fantastic. And I would also recommend speaking to Ali's colleague, Father Michael, who is an ex-pastor and is now a men's counselor and coach. He gave the keynote at Silverback last year, and it was one of the best speeches I think I've ever seen. It was amazing. So he's also fantastic, because he, you can tell that he's given a lot of sermons. He speaks very well.
Is he ex-pastor? Like he's still Christian?
Yeah, and that's the thing that I really appreciated, because as someone who grew up with a pastor for a father, he brought through the positives of the Christian message in a very secular, non-religious speech. And that's where I love seeing religious people speak, is that they don't reference the Bible or God or Christianity, but they talk about the merits and the virtues and the values that are taught from the Bible, but then bring it into other things. So he's awesome, because it's sometimes when it comes to working with counselors for men, they need a certain type of guy. And some guys need a guy who's angry and aggressive, and some guys need a woman, and someone needs someone soft. And Father Michael's like a really good dad or uncle that you can speak to, like an older wise guy. And
to get in touch with him and get him on. Yeah, I'm a Christian myself, so I didn't know if you know that. So it'll be good to chat about that stuff. So is he on Instagram?
Yes. Yeah, he's awesome. And yeah, Ali will be really stoked, because we've been saying for a while, like, he only got into this space, about a year ago, I think. And we need to get him on a bunch of podcasts, because he's got a lot of really valuable stuff to say.
Amazing. Well, Dave, lastly, how can guys get in touch with you? Website, socials, and things.
Yeah, so if people want to book in with me for any kind of consultation or check out my ebooks, they're on advancedfundamentalhealth.com. Otherwise, I'm most active on YouTube these days and Instagram, probably YouTube actually. So YouTube is Dave Lee TRT. I've got a bunch of long form to 20-minute lectures on there that I try to give away as much of my knowledge as I can. And also on Instagram, which is I'm Dave Lee, so IMDAVELEE. And if you want to join my private network, which has like exclusive content and Q&As and stuff like that, there's a $19 school group you can check out off the Instagram. And I always say this at the end of an episode, but if anyone's listening and wants my ebooks but isn't doing well financially, just send me an email and I'll send you all 3 of them.
Appreciate that, Dave. And hopefully, a few months down the line, we'll get on another podcast. There'll be new stuff to chat about TRT, and we'll see some of the future stuff that you've said about hopefully starting to be implemented.
Yeah, I hope I can reference this video in 10 or 15 years and be like, see? I hope so. That's
exactly. So, Dave, you have an awesome day, and thank you for joining us.
Thank you for having me once again.